والله ما يلا يلا.
So just for you to remember, when do we use laryngotracheal reconstruction instead of cricotracheal resection? Every time the posterior interarytenoid space, whether it's a congenital origin or an acquired origin, when this is narrow and the arytenoids cannot open during the inspiratory phase of the respiratory cycle. So this is typically when you have a glottic web, because this area is still insufficient. Once you have divided the vocal cord and you have a subglottic stenosis combined with this, you need to put a posterior graft here to enlarge the distance here. In an elliptical cricoid, I already told you that the anterior-posterior distance of the glottis is normal, but it's very narrow laterally. So you really need to expand the airway not only posteriorly but anteriorly. And when you have a posterior glottic stenosis, with or without fixation of the cricoarytenoid joints, you need to do this. And you can imagine that in this case, which is much worse than this one, most likely the arytenoid will be completely fixed. So how do we do this? If we do a laryngotracheal reconstruction for a purely glottic problem, so it means posterior glottic stenosis, but the subglottis is fully normal, we never transact completely the laryngofissure here. We make an inferior midline laryngofissure up to the level of the vocal cord, the anterior commissure here, and I remind you that the vocal cords are inserted at mid-distance from the thyroid notch here to the inferior margin of the cricoid plate, of the cricoid, of the thyroid, the cartilage, excuse me. Then you have to cut also the cricoid, and usually one first ring, sometimes two. And then you can expand your airway, and you can open posteriorly right in the midline on the cricoid plate. It's very important to be strictly on the midline, and I will show you how you do this. So I repeat that this type of laryngotracheal reconstruction is just for isolated subglottic stenosis or posterior glottic stenosis. And when it's isolated subglottic stenosis, it's a minor grade of stenosis, a grade 1 or a grade 2, but not 3 and 4. So you transact the anterior cricoid arch and the upper two tracheal rings, and you try to preserve the anterior laryngeal commissure. The other advantage of this, you have to realize that if you do a full laryngofissure and a posterior cricoid split, your larynx is doing this. So it's destabilizing very much the larynx, so you have to be careful, because in your reconstruction, if you are not suturing the posterior graft very well, then your larynx is going to waggle like this, and if you don't have a good stent to stabilize your reconstruction, then you may have some deformity. This is why in the failed surgery that you see sometimes, you see overlapping of the arytenoid, because the posterior graft has been tilted and the posterior graft has not stayed well in place.
For most patients with that type of procedure, would they have a tracheostomy already or no?
Well, some of them don't, and some of course have. It depends on the severity. For instance, if I come back here, such a child, a newborn, can live several months with such a tiny opening. But when you see that, you cannot say whether the child is breathing sufficiently, so we'll postpone the surgery, because he's at risk of having total obstruction, just a small upper airway infection, and he will be having a very compromised airway, as well as this one. This might the patient might tolerate this very, very well. This is also a problem. This is a good question because this is a problem. When, for instance, the parents see a child without a tracheotomy and you say, okay, I'm going to do a reconstruction, put a posterior graft, but I need to put a temporary tracheostomy. Most of the time they don't like it at all because they said, my child is now without a tracheotomy, you are not going to put a hole in his neck. But sometimes you have to do it, you know. This one, of course, would be with tracheostomy already because the residual airway is so small that, of course, you cannot breathe through this airway.
How do you manage the airway during the surgery if they don't have a trach?
If you don't have a trach, it's a good question again. So you prepare the trachea. Ventilation might be a problem for the anesthetist. So when they have a marginal airway, we use usually a laryngeal mask to ventilate them. And then we prepare the anterior part of the trachea and we make a horizontal incision between two tracheal rings and we ventilate them from there. Either at the end of your surgery, if your reconstruction is a big complex and you have a stent, then you will keep the tracheostomy, or if you want to do a single stage surgery, then it's very easy just to put a few stitches and close your temporary tracheostomy. What you are going to learn today is to do a full laryngofissure like this. So to do a full laryngofissure, usually when you have prepared the trachea, you will have here, it's not depicted on this diagram, but you will have the cricothyroid muscle on either side. You don't touch these muscles because this is strictly a midline surgery. So you start making a vertical cut from the first tracheal ring or from the anterior arch of the cricoid, and in order to stay in the midline, because in newborns, for instance, the thyroid cartilage is not V-shaped like this, it's more round-shaped. So you can make a mistake in being slightly off midline to cut through the anterior commissure. And a trick to avoid damaging the vocal cords too much. Your laryngofissure, you use a mosquito and you open the mosquito towards the vocal cord, so you spread the vocal cord. Instead of having vocal cords like this, you try to make them like this because you have spread the anterior commissure with the opening of your mosquito. So the gesture is to go in, lift up, and spread. And then you aim at the thyroid notch from here, so you're in the midline, and then you do your laryngofissure. And try to do it just at once, not going, and making several cuts. The cut has to be really clear here. Then you expand the airway here that you have open. You can go and cut also through the petiole of the epiglottis. And you start always to do your posterior grafting. If you want to do only an anterior grafting, then of course you're not transecting the anterior commissure. You will stop at this level, and then you will put just an anterior graft here. But for this workshop here, you will learn how to do a full laryngofissure, and when the larynx is open, I will show you, it's difficult to demonstrate here, but I'll show you how you recognize the position of the vocal cord when the larynx is fully open. The trick is to use again the mosquito, and you look for the ventricle. And so what is below the ventricle will be the vocal cord, what is above the ventricle will be the ventricular bed. So once you have done this, you will harvest the posterior graft, and you see for an anterior grafting, you will carve this as a boat shape, and when you will do your posterior grafting, you have a rectangular graft here, but I will show you this in more detail. So the anterior laryngotracheal fissure that you do is for glottosubglottic stenosis, not just for glottic problem like when you stop at the mid portion of the thyroid cartilage. So you do your full laryngo fissure as I explained, and you section the anterior cricoid arch and 1 or 2 tracheal rings to have a good exposure. The precise midline incision is difficult when you have severe stenosis. And usually this laryngotracheal reconstruction, we never use it for grade 4 stenosis, which corresponds to a total obstruction of the airway. There we do a cricotracheal resection. But there are unfortunately some cases where you have to do this because of recurrent stenosis after failed previous surgeries, and you cannot further resect the airway. So you have to do this, and it's more difficult to be strictly in the midline because you are incising through something, you have no possibility to put your spreader for preserving the vocal cord.
So in such case, can I open the airway from above if I couldn't get the midline from below?
Yeah. For instance, the first case that you saw, congenital webbing of the vocal cord, the very long webbing of the vocal cord with a tiny residual opening, I do my laryngo fissure from cranial to caudal. So what I do, I transect vertically the petiole of the epiglottis at the notch of the thyroid cartilage. I do a very meticulous hemostasis because I want to see well, and then I use 2 skin hooks, and I try to open the airway. Then with my 15 blade, I'm going down. I know that the insertion of the vocal cord will be at mid-distance from the notch to the inferior margin of the thyroid cartilage, so I don't go further than this. I further pull on my skin hooks,
Yeah.
and since in small children the cartilage is soft and pliable, you can really open this like a book, and then you see the glottic plane, and with your knife you can go from posterior to anterior, and you can cut in between without damaging the vocal ligament. This is extremely important. If you do this surgery well, I have done that in several patients. After that, they can even sing, you know, so you can restore a very good voice because there is no scar. This is just a congenital anomaly, and if you don't damage anything at the level of the vocal cord, you will have a very good result.
In such case, I have to fix the reticle again to the thyroid. When I open from craniocaudally, I have to fix the
well, when you do this, you open completely like a book, and then you do your posterior cricoid split. You put your graft posteriorly, and then you put a graft anteriorly. The cricoid ring is too thick. Another trick is to use an elevator. You elevate the mucosa laterally, and with a small diamond burr, you can carve out also the cricoid ring to gain space laterally, and it's increasing the size of your airway.
So I mentioned about the fixation of the epiglottis. If I open from above, I have to fix the epiglottis to.
He's talking about fixing the epiglottis that you open from going top down.
Yeah, well, you transect the epiglottis, but then when you close your laryngo fissure, you do a pexy of the epiglottis. I can show you how you do this. It's very important to bring the epiglottis anteriorly, because you see some cases, redo and redo cases, when the epiglottis is pushed backwards, and sometimes you see the picture of the epiglottis reaching almost the level of the arytenoids. But this is really bad. You should never come to this situation. So for the posterior graft, I always try to harvest one of these costal cartilages because the outer surface is flat. And this is what you need for a posterior graft. So it's between the 6th to the 9th ribs here, and because of the flat outer surface, as I just mentioned, and this part is pretty straight. You don't want to have a curved cartilage graft here, and the width is estimated to be about 1 millimeter per year of age. So it doesn't work very well. This is a rule of thumb that Robin Cotton established, but the newborn, you cannot put just 1 millimeter. You start with a minimum of 4 to 5 millimeters, and you have an 8-year-old boy, you are trying to have an 8 millimeter width of your cartilage graft. But as I said many times, you are limited by the width of the rib anyhow. So if you need a very large rib, sometimes you cannot create the flanges because you lose some width of your graft. So you just cut it vertically and then you suture it to the divided portion of the cricoid plate. How do you carve an anterior rib? So you have the perichondrium. Remember, this is extremely important. The perichondrium should always be facing the lumen. If you make a mistake and you put it the other way around, your graft will be destroyed because the only protection that you have inside the airway is the perichondrium. So you have a square rib here, and then you measure the distance on the outer surface of your trachea, and remember that the largest portion of your rib, of your carved rib, should be where you had the stenosis. I have seen some cases where they did put the largest portion on the first normal tracheal ring that had a normal lumen, and at the level of the cricoid it was insufficient, so you should place the largest portion exactly where you have the stenosis inside. And so you carve it in a boat-shaped fashion, and you keep these flanges. When you keep the flanges, it's avoid that your graft will drop into the airway. The suturing is done in this way, so you go from outside in, and you should emerge right at the level of the perichondrium edge here on your boat-shaped graft. Now I have changed slightly this. I do mattress sutures. So what is the difference? So I go in like this, then I go from inside out, and I tie the knots on the outside. I will show you how we do this on the model. Okay? For the posterior graft, so again you start with a rectangular graft, and you carve out and you create these flanges if you can. Usually your graft is too thick, so you have to trim down here your graft so that the flanges have about 1 or 2 millimeters thickness, not more than this. If you put more than this, then your graft will be too thick. The technique of suturing is you go from the inside through the perichondrium, and you try to emerge right at this angle. Another point that is important, the height here should be matching the height of your divided cricoid plate. You don't want to have something that is higher here or lower here. When you have to measure this distance here and report this distance here on your graft so that you have exactly at the end your perichondrium should come flush with the mucosa of the divided cricoid plate.
How can you control this? If we have to preserve the perichondrium from the inside, then we cannot keep it like that.
Yes, you can. Of course, you can do this. You can once you have divided here the cricoid plate, you can measure here the thickness of your cricoid plate. Okay, and when you have your graft here, you can also decide that I'm going to have 2, 3, or 4 millimeter thickness here, and then you do your horizontal cut, and you create your flanges, and then you cut the excess like we did before. Here you cut the excess here so that you have nice flanges. You can do it perfectly well.
Yes.
A trick